So welcome everyone. We start this Monday today under the aegis of ISOPAR, where we are going to talk on high-risk pregnancy. This program is brought to you by Bharat Serums and Vaccines under the Bridging Bharat initiative. These are a simple do's and don'ts for all the webinars. I'm sure you have been doing many of them, but this will be good to document it this way. Now, may I request Dr. Anju Soni to kindly introduce the convener, Dr. Lakshmi Shrikhande.
You stop your screen sharing. Anju, I am sharing my screen. Yeah. Can you see Anju?
Good afternoon. Yeah. Can you go to good afternoon, everyone. Dr. Lakshmi, Dr. Suchitra Pandit, Dr. Jaideep Tank, Dr. Anita, Dr. Sita, Dr. Nilima, and Dr. Kiran. It's my privilege and all the participants who are in the webinar. It's my privilege to introduce the very dashing and strong lady I have met in my life is Dr. Lakshmi Shrikhande. She is Medical Director Shrikhande Fertility Clinic, Nagpur, and Chairperson Designate ICOG 2020. She is past Vice President ICOG, past Senior Vice President Foxy, and also Patron and President Vidarbha Chapter of ISOPAR. Received Nagpur Ratna Award at the hands of Union Minister Nitin Gadkari. Received Bharat Excellence Award for Women Health. Received Meru Dara Hinsotia Award for Best Committee of Foxy. Past Chairperson HIV and AIDS Committee Foxy. Immediate past President Menopause Society Nagpur. Past President Nagpur OBGY Society. Visited 96 Foxy societies as invited faculty. Delivered 11 orations for 450 lectures and publications 20 national, 11 international. Sensitized 2 lakh adolescent boys and girls. Welcome Dr. Lakshmi for this beautiful conceptualized webinar you have created.
Thank you, Dr. Anju, for kind words. Myself, Dr. Lakshmi Shrikhande, Patron and President of ISOPA Vidarbha Chapter, welcome all the participants for this live webinar on a dedicated topic, that is Rh immunization. For this webinar, we are privileged to have two eminent experts with us. First is Dr. Jaideep Tank, who will be delivering a talk on Rh immunization, followed by a case-based panel discussion, which will be moderated by Dr. Suchitra Pandit. It's my privilege to introduce both the experts to all the participants. Dr. Jaideep Tank is currently Honorary Secretary General of our Foxy. He was immediate past President of Mumbai Obstetric Gynec Society. He is Chair International Federation of Obstetrics and Gynecology FIGO Committee for Safe Abortion. He is Deputy Secretary of Asia Oceania Federation of Obstetrics and Gynecology. He is ex-chair Publication and Newsletter Committee of AOFOG. He was MTP Committee Chairperson of Foxy way back in 2004 for 5 years. He is Vice President for Forum
of COVID pandemic.
Please mute. He was Vice President for Forum for Enhancement of Quality in Healthcare. Now coming to his personal achievements, he is consultant Ashwini Maternity and Surgical Hospital. He is having 15 IVF centers he is supervising. I just want to highlight his achievements in FIGO and Foxy, what he has actually done. He is instrumental in drafting the proposal for FIGO, which has resulted in a grant of $13 million for a 10-country project, and he is the technical lead for that project. For Foxy, he has worked very hard on the amendments to the MTP Act with Government of India. He drafted the proposed guidelines for abortion beyond 20 weeks with Government of Maharashtra. He is part of several technical advisory groups and committees of Government of India. He has what e-elections we are seeing. He contributed to the electronic membership management system and e-voting for Foxy. He developed a completely redrafted, user-friendly constitution for Foxy, contributed and has led to the development of the Foxy statements on cesarean rates, hysterectomy rates, contraceptive implants, ART bill, surrogacy bill, and other interventions in Supreme Court on PCPNDT, the RII case, the oxytocin case, and other case. He has restructured the Foxy cells, the minutes of the Foxy MCM and GBM, and several other initiative. Friends, these achievements are too vast for me to elaborate because it will take me more than 1 hour. But I must say he is a very humble, dedicated, down to earth personality. I really don't know when he eats, when he sleeps. I mean, he has devoted so much time to Foxy, and I wish him all the very best for his Foxy presidential election. Friends, the voting will be next year, and wish you all the very best, Jaideep, for your presidential elections. The next speaker is Dr. Suchitra Pandit, who is conducting case-based discussion on RH immunization. Dr. Suchitra, she is consultant, Department of OBGYN, Surya Group of Hospitals at Mumbai. She is chairperson of AICC RCOG from 2017 till 2021. It is my privilege that I am having National President of ISOPA with me for this webinar. She is also the president of Gestosis organization. She was president of Foxy ICOG in 2014-15. She is Foxy representative to AOFOC from 2015 to 17. She was chair of SAFOC Medical Education Committee, president of Mumbai Obstetric Gynec Society way back in 2013. She was professor and unit chief at LTMMC and LTMG Hospital, Sion. She has the teaching experience of 33 years. She has initiated Foxy Gestosis Hypertensive Disorders in Pregnancy Certificate course, and she personally has conducted 105 courses so far. She has conceptualized Foxy Youth Mela for empowering youth and conducted more than 300 melas, and still it's an ongoing activity. She has contributed actively in the formation of GCPR guidelines, participated in 8 guidelines. She is faculty for TOG committee from 2018 to 2020, and she is secretary of Foxy UNICEF Sion Kishori Adolescent Empower Project. Friends, she has got many publications to her credit. She has 125 publications. She has authored 5 books, and she has been awarded with 35 orations. She has won several prizes, and she is regularly invited as a subject expert to speak. So friends, I am honored to have Dr. Jaideep Tang and Dr. Suchitra Pandit with us for this webinar. Now I invite Dr. Suchitra Pandit to introduce our chairpersons for this webinar.
Can I have the CV
Session chairpersons का introduce slide दिखाओ. Welcome Girija.
Hi, so first of all,
hi Lakshmi, how are you?
Thank you very much,
Dr. Madam, Pandit Madam. Hi, Dr. Soni.
Can I start?
Yeah, please.
Yeah.
Soni is the senior consultant of the OBGYN department at the Soni Hospital and Manipal Hospital at Jaipur. Special interests have been high-risk pregnancy, critical care, gynae, minimal access, urogynecology, menopause, and yoga vidya, which is very, very interesting. She's been the chairperson of the HIV/AIDS committee in 2022, president of Jaipur Society 1819, president of the Jaipur Menopause Society, has been the chairperson in the Public Awareness Committee of Indian Menopause Society, has been the vice president of JOGS, secretary of IMS Jaipur, and life member of several organizations, and member of the PCOS Society of India. She's also a Foxy trainer for basic and advanced endoscopy and TOT prescription writing, MHT, Adbhut Matritva, and HIV/AIDS, and is editor of the Poise magazine. welcome Dr. Soni to the ISOPA webinar. Welcome as a chairperson. May I have the next, please? Dr. Anita Kotwal, a very, very shy lady, but she has, apart from doing obstetrics and gynecology, she's also done her law, LLBs, and she's been practicing in Gondia near Nagpur for nearly 24 years. She's been the president of Gondia OBGYN Society. Dr. Anita, lovely to see you and welcome to this webinar.
Thank you. Now I invite Dr. Jaideep Tank to go ahead with his presentation. Dr. Jaideep, please. Unmute yourself, Jaideep.
Right. So let me ask the two most frequently asked questions since the lockdown has started. Are my slides seen and am I audible?
Both, yes.
Thank you. Thank you very much. It's an honor and a pleasure really to be here for this very important webinar with the theme of high-risk pregnancy, focusing on RH isoimmunization. It's a particular honor to be introduced so nicely by Dr. Lakshmi Shrikhande, the convener and the president of the ISOPAD Vidarbha chapter. And I must also thank the secretary of the ISOPAD Vidarbha chapter, Dr. Alka Mukherjee. Suchitra and me go many, many years back. I remember ever since I have come into Foxy, Suchitra has been a constant, reassuring and also encouraging presence. In fact, when all this discussion about the e-voting came back, we were reminiscing about how the first discussions on e-voting happened when Dr. Suchitra Pandit was the president of Foxy. So thank you very much for that, Suchitra, and congratulations on being the president of the National ISOPAB. And thank you also to Dr. Meena Samant and Dr. Pragya Mishra, the Secretary General and the Treasurers. Thank you very much, Dr. Anju Soni and Dr. Anita Kotwal, the chairpersons. And I very much like the way this webinar has been designed. With me, not a fetal medicine specialist, but someone who does obstetrics day in and day out, to first talk about the broad brushstrokes of the whole RH isoimmunization issue, and then the fine paintbrush within this canvas of RH isoimmunization will be laid out by our expert maternal fetal specialists led by Dr. Suchitra Pandit and Dr. Girija Wagh, Chinmay, Sita, Dr. Kiran Gupta, and Dr. Nilima Thakre. So thank you very much for designing this webinar that way. That is also my way of telling you that please don't ask me too many questions. So let me begin first with this quite, fascinating history which surrounds blood types. And if you look at that picture over there, that's a picture from an original article written by Dr. Alexander S. Wiener, who was a collaborator with Dr. Lensteiner, when he described all the various antigens and the blood groups which comprise it. It's a fascinating article, and I like how this article stops by saying that it's not the discovery of the blood groups that is so important, but more importantly, what that discovery has led to, which is answers to the question of diseases like hemolytic disease of the newborn, hydrops fetalis as it was called at that time, and obscure blood diseases. As Michael J. Fox, who himself suffered from Parkinsonism and has a foundation to fund work on Parkinsonism, said, medical science has proven time and again that when the resources are provided, great progress in the treatment, care, and prevention of disease can occur. And this is exactly what has happened with RH isoimmunization. So these are the talking points for the presentation. We'll talk a little bit about epidemiology, then a little bit about pathophysiology, because I think that by the time we finish our post-graduation, pathophysiology sometimes gets a little left behind. And really speaking, without understanding the pathophysiology, it's quite difficult to understand the antenatal management, either the prophylaxis or even the management of an alloimmunized pregnancy. So let me begin by saying this first, that a blood group system is essentially a group of antigens which have homologous genes which are sort of responsible for regulating them, if you will. Sorry, I'm just adjusting my screen a little bit. Okay. And we have two of the most common systems for blood group classification, that is the ABO system and the rhesus system. Within the rhesus system, although there are several antigens, it's the D antigen which is considered to be the most immunogenic, and that's why the D antigen is actually called the Rh factor. There is a heterogeneity in population as far as the Rh factor is concerned. It does not exist equally, in all populations of the world. For example, it seems that the Basque population of Spain has the highest incidence of Rh negativity, but it varies from as much as 30 to 35% to 15 to 17% in European and North American descent. And fortunately, it's not really that common in India. Our incidence is said to be between 3 and 8%, and it's, of course, the rarest in Asia. Let's look at the terminology when we want to understand isoimmunization. So, the immune globulin used specifically to bind the RHD antigen is referred to as the RHD immune globulin, or what is more popularly called as anti-D immune globulin, or simply anti-D. Alloimmunization refers to an immunologic reaction against foreign antigens that are distinct from antigens on an individual cell. In this case, it refers to the maternal formation of antibodies against fetal Rh factor. And the maternal fetal hemorrhage is the term used to identify varying amounts of the fetal cells in the maternal circulation when there are small breaches in the fetal maternal placental interface. It is said that you don't really need a very large amount of fetal blood to provoke this kind of an antibody formation. As little as 0.1 ml of Rh positive cells has been known to result in evoking this kind of a response. There is a flip side to it also, because studies have suggested that up to 30% of persons with Rh blood never develop Rh incompatibility, even when they are challenged with large volumes of Rh positive blood. And we will talk a little bit about how we can distinguish between them. So therefore, Rh alloimmunization occurs either after an incompatible blood transfusion or after feto-maternal hemorrhage between the mother and an incompatible fetus. Over here, of course, the term incompatible simply refers to the blood type of the fetus. Feto-maternal hemorrhage, or this breach between the maternal and fetal circulations, occurs either during pregnancy, around 10% of cases, or during delivery. Even if there is not a complete breach, fetal RBCs have been detected in the maternal blood in all 3 trimesters without there seeming to be an episode of feto-maternal hemorrhage. As happens with almost all antibodies, when the maternal circulation is exposed to these Rh factor, it has a production of IgM antibodies, but the IgM antibodies do not cross the placental barrier from the maternal side. And after 6 weeks to 6 months, the IgG antibodies form, and these are the ones which are able to cross the placenta and then destroy the fetal Rh positive cells. And therefore, typically, firstborn infants with Rh positive blood type are not affected unless the mother has already been sensitized earlier, for example, by a blood transfusion, etc. What happens if the mother is sensitized either by a previous pregnancy or a blood transfusion? The maternal IgG enters the fetal circulation and starts destroying the fetal cells, by specifically the fetal red cells. Because the fetal red cells get destroyed, heme is formed and it's converted to bilirubin, which causes fetal hyperbilirubinemia. And both are normally neurotoxic and are effectively cleared by the placenta and metabolized by the mother. But at a certain tipping point, the cell destruction exceeds the cell production. And when this happens, severe anemia occurs. There is more demand on extramedullary sites to produce more red cells, which ultimately results in hepatosplenomegaly and heart failure. It's like a congestive heart failure with ascites, edema, pericardial effusion, the classic erythroblastosis fetalis. Hydrops fetalis occurs when the hematocrit falls below 15%, and this often results in fetal death shortly before or after birth. There is a predisposition between male and female feti to have this syndrome. Unlike some other conditions, for example, when a patient is tested positive for VDRL, we know that when a patient is tested positive for VDRL, results in pregnancy improve with every pregnancy. In RH sensitization, the results actually deteriorate with the number of pregnancies. Without prophylaxis, the risk is 16% of problems after 2 deliveries, and with prophylaxis, you can drop the risk to less than 0.1%. The risk of having RH sensitization depends on the volume of transplacental hemorrhage, the extent of the maternal immune response, and of course, the concurrent presence of ABO incompatibility. Of course, one must remember that RH incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in the future. This has sometimes raised the clinical question that if an RH negative mother delivers an RH positive child, and then she wants to go for a tubal ligation, should you give RH, the anti-D vaccine? And we will address that issue later. So if you want to know or look for potentially sensitizing events, then you have to ask for the history of all this, including abortion, invasive procedures like amniocentesis, abdominal or pelvic trauma, antepartum hemorrhage, and even, for example, history of hydrops, mechanism of injury, presence of vaginal bleeding, or a prior invasive procedures. Once you have this history, then you want to know whether this patient can be triaged into someone who's sensitized versus not sensitized. Or, for example, someone who has not been sensitized simply because she's pregnant for the first time. So the objectives of antenatal management in short would be to prevent the alloimmunization in Rh negative unsensitized women, early detection and treatment of fetal anemia. And if you want to know whether they are sensitized or not, then you have to do the indirect Holmes test, otherwise called the antibody screen. And this looks like a complicated slide, but in fact, if you look at it closely, it's not. So on one hand, you have a woman who's Rh negative and a father or a partner who's Rh positive. You will then do a maternal antibody screen at 20, 24, or 28 weeks of gestation, depending on the history. If that antibody screen is negative, which is what we are talking about right now, that is a non-sensitized person in probably her first pregnancy, and if it's negative, then you have to administer 300 micrograms of immunoglobulin at 28 weeks. There is some controversy about it, and you can talk about the doses, but yes, this is pretty much standard. At delivery of the baby, check the Rh status of the newborn. If the child is negative, no further treatment is required. If the child is positive, then within 72 hours, you have to administer 72 hours of delivery, 300 micrograms of NTD. I'm not going to go into the other part of the slide because that is something we are going to talk about a little later. I remember when I was in second MBBS and we used to talk about direct test and indirect test and so on and so forth. It used to be a little, confusing for me. When do I do the direct and when do I do the indirect? It's quite easy actually to remember. The indirect detects it in the patient's serum and the direct detects it in the RBC. So normally for the mothers, you do an indirect test, and for the child, you do a direct test. If you are looking after a woman who has not been sensitized so far, you have to still take certain precautions at the time of the delivery of this kind of a mother. You have to have a consultation with the neonatologist. Don't give oxytocin. If manual ramal or placenta is required, do so gently. If blood transfusion is indicated, use Rh negative blood, and early clamping of umbilical cord in this particular circumstance is indicated. You can consider to leave a long length of the cord in case the child requires some kind of a exchange transfusion, etc. Later on after delivery. These are all measures which are essentially taken to reduce the amount of feto-maternal hemorrhage, and therefore gentleness is key. Another practical point I would like to share here is that if you are looking after a mother who's Rh negative, it's a good idea to get her blood ready and counsel her relatives about the relative rarity of obtaining Rh negative blood. So be in touch with your blood bank. Make sure that you have spoken to the relatives that Rh negative blood is not always easy to come by, and therefore it is quite advisable to make arrangements right from the beginning. Once the child is born, you could send cord samples for Rh typing, DCT, that's the direct test. Now that's for the baby, hemoglobin, bilirubin levels, and a peripheral smear. And as we have already said, if the fetus is Rh negative, the child now, there's no further intervention. And if it was Rh positive, you could either determine the dose of Rh IgG, which can be detected by a 4-step lab procedure. We are going to talk a little bit about that. Or you could directly give the patient anti-D. So the normal amount of fetal blood that enters the maternal circulation is actually less than 0.5 ml. And a dose of 300 microgram anti-D will neutralize nearly 30 ml whole fetal blood. So it should be quite enough in normal circumstances. However, if there have been circumstances where you expect that a high amount of fetal blood has gone into the circulation, for example, accidental hemorrhage or fairly difficult manual removal of placenta or a large amount of PPH, etc., where a lot of massaging, etc., has been done, you can give a higher dose of anti-D. But if you're planning to give a higher dose, it might be a good idea to first do the 4-step lab procedure and determine the exact quantum of feto-maternal hemorrhage, where essentially you do a rosette fetal RBC scoring. And if you get a positive rosette, then you do an acid elution test. The acid elution test has come under some criticism for it not being as specific and as it should be, and you can do a flow cytometry. However, flow cytometry is not always very easy to come by. For sensitized women, and you have to know whether there has been a history of an affected fetus in the previous pregnancy, because as I said, it worsens over a period of time. You have to know maternal antibody titers where there is no prior history. And then, you have to determine sensitization by doing the indirect Coombs test. So let's look at what to do in sensitized kind of a situation. If there is no previous history of an affected fetus, you get the blood group of the husband. If the husband is Rh negative, then that's fine. You don't need to do anything. If the husband is Rh positive, then do an antibody titer. If it's below the critical level by 36 weeks, you can continue the pregnancy, but we'll talk a little bit about how to monitor further. If the antibody titer is beyond the critical level and she's post 34 weeks, then you can consider that you should deliver that patient. If she is less than 34 and the antibody titer is beyond the critical level, then you need to monitor with PSV of the middle cerebral arteries, and then even may consider doing an amnio, an ultrasound, or even a pulp sample. If there is a previous history of the affected fetus, then you still have to establish sensitization if you are unsure of why there was hydrops for that particular fetus, and then carry on with the entire gamut of chordocentesis and amniocentesis and middle cerebral artery Doppler surveillance. Now, this is an example of how technology can reduce intervention. The middle cerebral artery Doppler velocimetry is found to be an accurate and non-invasive screening tool with a very high sensitivity of 100%. You can understand it's not possible to have sensitivity more than that. And a 12% false positive rate, which is really quite low for anemia. And as I said, the use has resulted in up to 80% reduction in invasive testing. Remember, however, that this is not useful before the 18 weeks of gestation and not a reliable predictor of severe anemia after 35 weeks of gestation. It's actually been found to be similar or even better sometimes than amniotic fluid OD40 in the prediction of anemia. So how do you interpret the MC, the middle cerebral artery velocimetry? In an unaffected or a mildly affected fetus, you'll get a normal report. In a moderately affected, you'll get MCAD about 1.5 MOM, and then you need to repeat it 1 to 2 weekly and consider delivery after lung maturity. In severely affected, you'll get a MCAD of more than 1.55 MOMs, or there is a frank evidence of fetal hydrops, and there is, of course, a high risk of intrauterine fetal death. In case you come across this point where you need to intervene, then there you have to go ahead with a fetal assessment of the hemolysis, either by amniocentesis and checking OD40 or a fetal blood sampling and checking the fetal hemoglobin level. There are these various spectrophotometry charts, and the Queenan chart might actually be a little better than the traditional Livy chart. So if you have an RH sensitized, you start by doing middle cerebral artery Doppler velocimetries, and depending on that, you decide the further steps of whether to do an intervention or not. If it comes to that and you need to do intrauterine blood transfusion, remember that it's done for severe anemia in utero, and it's typically carried out between 18 and 35 weeks. You could either give it intraperitoneal or intravascular. I understand that the intravascular is a little more difficult technically, but is now the preferred way to administer this. It's fascinating to know that when you do it intraperitoneal, the peritoneum acts like some kind of a dialyzing membrane, and there's sort of a physiological kind of a dialysis which occurs. ORHD negative packed cells with hematocrit of around 80% are used, and there is a formula to calculate in ml how much to do. As I said, now it seems that an intravascular blood transfusion is the method of choice if it can be done in technical terms. If you can't, then you can still consider an intraperitoneal. If you are looking after a sensitized Rh negative woman, then the postpartum management of the neonate is crucial. You should admit the child to the NICU. And if the child is affected, then an urgent exchange blood transfusion is indicated moderate to severely affected neonates. If it's a mild affection in terms of the hemolysis, then a phototherapy should be good enough. Remember, and this is important, in fact, in the UK, they have documented that the large majority of alloimmunizations now occur because of non-administration of anti-D after an abortion. So whatever the situation, keep RH status in mind, and if it's required, give these doses which are recommended at abortion or invasive fetal procedure, antepartum hemorrhage, and even external cephalic version. So there are some recent advances which have taken place. For example, non-invasive fetal RHD genotyping, point of care tests, a lower dose, and the concept of partial antigens, partial weak antigens. I'm assuming that this is the kind of fine detail, even with regard to the technical know-how of how to do intrauterine blood transfusions, that's going to be addressed after this presentation is done. So to summarize, every woman of childbearing age should have her ABO and RH types done. If the patient is RH negative, you should go ahead and get the husband's RH test. Try to do the indirect womb test at 20, 24, 28 weeks with appropriate prophylaxis. A single postpartum dose may sometimes be inadequate, and that's where the importance of giving a dose at 28 weeks. And as I already told you, that it seems that in resource-rich settings, the most common reason for having alloimmunization is actually omission of the immune globulin. So always keep this at top of your mind when you're looking at Rh negative patients. There are, of course, problems. It's not all very rosy. There is a high cost of the immunoglobulin. There is a lack of resources, a low turnout sometimes in some settings at antenatal clinics, poor documentations of prior sensitizing events, even loss of case notes. And there are some things which have been suggested, like advocacy for partnership by government and NGOs to subsidize the cost, and maybe a special insurance cover for Rh negative women to ensure ease of procurement when needed. So I will end with this fairly encouraging slide. On this side, you see identification card of a mother who is Rh negative, and she has said on that card, and she takes it with her everywhere, so that when she goes to the hospital, she tells the doctor and gives her that card to make sure that the doctor knows that she's Rh negative. But I'd like to end with this uplifting message from the ACOG practice bulletin, which says, advances in the prevention and treatment of RHD alloimmunization have been one of the great success stories of modern obstetrics. And I think sometimes, at least, we have to step back, reflect, pat ourselves on the back before we move on and manage these kind of patients. Thank you very much.
Dr. Anita, you can give your chairperson's remarks. I invite you to give your remarks.
Thank you.
Dr.
Thank
Anita.
you. Yeah, thank you, ma'am. Thank you, Dr. Tan, sir. It was a very elaborate and a very nice presentation. You have to rush for your cesarean section, so I won't delay in all the goodies and all the nice things. But thank you, sir.
Thank
You
you so
have
much,
to
madam.
wait, Jaideep. There are many questions for you. Just give us 5 to 10 minutes.
Yes, no
I will
problem.
quickly read the questions and you can answer. Dr. Sasikala wants to know, does all primary gravidas needs to be tested for ICT routinely?
Well, in an ideal world, I suppose you should, because there could have been some incident missed in the past. And remember, this is for RH negative women. So the first step is to do, the RH for the husband. And if the husband is also RH negative, that considerably reduces the risk of the woman being alloimmunized. So for RH negative women, we routinely do ICT at around 18 to 20 weeks. I think this is again something which the panelists can deliberate, and you will have a host of opinions about this.
Second question is, should we give NTD in cases of threatened abortion, medical management of ectopic pregnancy, medical abortions?
Absolutely, no question at all. In fact, as I said, right now in the UK, the most common cause of alloimmunization is not giving anti-D at the time of abortions. So whether it's an ectopic pregnancy, I understand the risk of having an alloimmunization with ectopic pregnancy is low. But rather than quantifying the risk by doing all the Rosette test and the acid dilution et al., it's so much easier to simply give a dose of anti-D and so much more certain, if you will. The chances that the dose of anti-D will be insufficient to cover that much feto-maternal hemorrhage is next to zero. It can occur occasionally. I'm not saying it can't, but that's next to zero. And I would believe that it's more cost-effective to give the anti-D rather than get into doing all the tests, etc.
What is the best time to give NTD in ANC cases? Dr. Meena wants to know.
Well, 28 weeks is recommended. If the patient is sensitized, then it becomes more controversial of whether one to give anti-D or not, and secondly, when to give it. I don't think there is any consensus at all on that. In fact, I have read some literature to show that even sensitized women postpartum should receive anti-D to blunt the effect. But I don't think there really is any consensus on that matter.
Maria Sheikh wants to know what should be the dose in cases of twin pregnancy.
Yeah, that it remains the same. You don't need to exceed the dose because the amount of feto-maternal hemorrhage that occurs is more or less the same. But, I think it might be a good idea, Dr. Srikhande, to leave some of these questions to the panel.
I understand you have to hurry. Okay.
No, it's not that I have to hurry.
Questions with Suchitra. Yeah.
Yes.
So you have to rush. Thank you so much, Dr. Jaideep Tam, for sparing your valuable time and giving such a comprehensive overview of RH isoimmunization. Thank you so much.
Thank you very much, madam. Thank you.
Thank you, Dr. Jaideep. It was really great. I think you cleared almost everybody's doubts. That was the best part.
Thank you.
And you are a very good presenter as such, so no need of, we can't just say that this one was good. Every presentation of yours is always amazing.
Thank you.
Outstanding. Really, one word, outstanding.
Outstanding.
Thank you, Girija. That's very nice of you. Thank you very much. Thank you.
Thank you.
Thank you, Jaideep. Now I invite Dr. Suchitra Pandit for the conduct of panel discussion. She is moderating the case-based discussions. Dr. Suchitra, floor is yours.
Yeah. Can I have the series quickly, please? Right. Thank you very much, Lakshmi, for inviting me to conduct this panel. A lot of points Jaideep has covered, but we can just reiterate some of them during the period of discussion. So I welcome all the panelists. Dr. Nilima Thakre is president of the Amravati Society, treasurer of the State Amongst Conference, and she's received the Shailaja Chaudhary Award for practicing OBGYN in 2019. Writes articles very regularly for Foxy Amongst journals and for souvenirs. And a special interest is obstetrics and adolescent health. That's how, Nilima, you're here on the panel. Welcome. Next, please. Dr. Girija Wagh. Girija is a professor at the Bharati Vidyapit, and she's also working at Cloud9 and she's the director of her own Girija Hospital. She is a very, very genuine gynecologist, a very, very sincere Foxy worker, and is excellent as far as her degrees and her knowledge is concerned. She's received the Anandibai Joshi Award for excellence in medical service, specializes in maternal fetal medicine and gynec endoscopy. She's a member of the steering committee of World Organization Justosis as well as vice president of the organization Justosis. She's a chapter assistant coordinator for National Eclampsia Registry and has been the chairman of the Medical Disorders in Pregnancy Committee and has been the joint secretary in 2013 to Foxy and national mentor for the Lakshya and the NPO's QCN program, along with the Ministry of Health and Family Welfare Government. Incidentally, Girija will be contesting for the vice presidential elections. The voting begins tomorrow. So friends, our candidate from West Zone, please, please, please make sure you put in your vote for her. The lines open tomorrow. Next, please. Dr. Chinmay Ratha, congratulations for winning the recent Foxy Committee Chair elections. And obviously, we welcome you to this chairperson's post of perinatology next year. She's been a FMF trainer in India. She's done the ICOG Foxy certification course and is the center of head for fetal medicine. 15 research papers have been published in peer-reviewed journals. She's a chairperson of the fetal medicine committee of the OGSH and an active participant in the academic activities of Foxy, ICOG, as well as RCOG. And Chinmay, welcome to this panel. And our next expert is Dr. Kiran Gupta. Kiran is a practicing gynecologist for the last 23 years. Currently is the president of Akola OBGYN Society and is also the director of the ICON. I love that name, ICON, Multi-Speciality Hospital, Akola. Next, please. Sita Ramamurthy Pal. So this is a lady from Kolkata, has been my student from Sion, currently the consultant fetal medicine and obstetrics at the Apollo Gleneagles Hospital, Kolkata, managing committee member of Bengal OBGYN Society, as well as chairperson of the Medical and Imaging Science Committee of the BOGS. He is zone coordinator of the Imaging Science Committee, Foxy, and clinical secretary of ISOPA, Kolkata chapter, and is also the faculty for the MRCOG Part 2 and 3 exam. So here we are with a very elite panel of gynecologists, obstetricians, and the fetal medicine experts. So now I will start sharing my screen. Right. So are the panelists all on board?
Yes,
And,
yeah.
Here we are with our expert panels. I'm not going to go into all these slides because Jaideep has just mentioned about them. So I'm just going to skip through that, the fact files, the RH isoimmunization, but I'm still going to dwell upon this slide because RH incompatibility we know occurs by two mechanisms. One is the traditional pregnancy and the second is spontaneous or induced abortion, trauma, or any invasive obstetric procedures. And the first pregnancy majority of the times is safe. But in the second pregnancy, what happens is the IgG antibodies, because they are the ones that can cross the placenta. The first time when you get the IgM antibodies, they don't cross the placenta. So the first pregnancy usually escapes. But the second pregnancy, these IgG antibodies cross the placenta, they bind to the FCY receptors on the trophoblast, and then they bind to the RH antigen and they play havoc because they trap the fetal RBCs in the fetal spleen and destroyed, and this results in anemia. And this will obviously depend on the amount of FMH and the amount of antibody formation. Can I request everybody else to mute, please? Again, Jaideep has already mentioned about this, but what we must remember that there were some 15 to 20% of RH negative women who have not had a problem. Probably there's an inborn ability to respond or there is a protection because of ABO incompatibility, or maybe the strength of the RH stimulus was very small, or maybe the fetal maternal hemorrhage is very, very less. And we must remember that this is like a blessing in disguise for them. But we remember that when there is an ABO compatibility, that's where the problem occurs, because those fetal R cells remain in the circulation and they can have a problem. So just a quick look at this slide and then we'll move on to the cases. First pregnancy is almost not affected. 1% during labor, 10% 6 months after delivery, and 15% by the time it's second pregnancy. So first pregnancy not affected. Second pregnancy there is an affection. And Girija, we'll have you because I know you have to jump on to another webinar. This is a 27-year-old primate walks into your clinic. She's 10 weeks and she's come to you for booking. She says that her mother's blood group was Rh negative, but she doesn't know. So how do you proceed?
Thank you, madam, for having me. Yeah, can you hear me? Am I audible?
Yes. Yes.
Yeah. So thank you for having me on this panel. At the outset, I would like to thank Dr. Lakshmi for allowing me to be here. And mostly, I would like to also remind and reiterate once again that from tomorrow, we are starting voting for Vice President. And before much ado, I proceed to answer the question, madam, that you posed in front of me. So if a patient, whether she comes with a family history or no, at 10 weeks of gestation, every woman should be having her blood group tested. So we will be doing her blood group and we will definitely find out and confirm that she's Rh negative or Rh positive. Anyways, all the other blood groups are also important. But since we are talking about the D, we have to do that. Secondly, if she comes Rh negative, then we must definitely ask for the husband's blood group. And if the husband's blood group is positive, then we all know that 50% of the possibilities are there, or even 100% that the baby will be Rh negative. If it is negative, then usually we do not have to worry further. Definitely when we do this testing of the husband, and if it comes Rh positive, we would label this as Rh incompatible pregnancy. Then we have to embark upon doing IDCT for the simple reason that if sometimes women may not tell you about miscarriages that they have undergone in the past, or they may not remember where anti-D was given or not. And therefore, it is important that we do the indirect Coombs test also at this point in time, and then we can take it on forwards. The moment we identify it as an incompatible pregnancy, we must set a sort of a protocol for her through the entire pregnancy. So she knows when to come for follow-up so that she does not miss on her prophylactic antibody, as Dr. Jaideep told us. And so she does not miss screening, because today we know that all of the screening is beautifully and effectively done on color Doppler. And I'm sure you're going to deal with that as the panel goes on.
Girija, what I wanted to also check was, would you be suggesting antibody screening for all pregnant women in the antenatal period? I know it may be a little expensive proposal, particularly in a public hospital, but would you think that if given an ideal situation, you would perform antibody screening for all the irregular antibodies?
Ideally, I would like to do it, especially because, many of these, we many times take our patients we sort of take them, we judge them, we feel that they know everything. But I have experienced in my practice that even doing a blood group again repeatedly and confirming it at the outset is very important. So simple thing like that, antibody definitely in these patients who can have an access to these things.
Absolutely. Thanks for bringing on the point that we must double check the blood group and there should be a written record. Don't just go on verbals. Now, this particular patient is Rh, BRH negative, husband is ARH positive. When would you do the anti-Rh antibody titer? You said you would definitely do it at booking. Then there onwards, supposing that booking is negative, then when would you repeat it?
I would do it at the 12-week scan. I always believe in that 12 weeks point line. 11 to 13 weeks is a wonderful platform and a window of opportunity to establish everything under the sky. Because once I know what's happening there, then I know exactly how to take things on. So that would be my first point in time. And then, of course, we will be doing it again at the 20.
So you've done it. Then when else would you do it?
20 weeks, 24 weeks, 28 weeks. And sometimes if I see that there is a little, sort of any suspicion on my Doppler or ultrasound, because at 24 weeks, if I've done a screening for some other reason, and I find that there are some abnormalities, I would like to again do it and confirm.
Excellent.
In this section, one more thing, Suchitra, I would like to add is when
Yes.
she's coming for a 19-week scan, like usually many of our patients are high-risk patients, so at 16 weeks only we advise them an early anatomy scan. But in case we haven't done that, at 18, 19 week scan, I'll definitely write on my requisition that this is an RH incompatible pregnancy. Please take a look at the MCA. This will be my point when I'll always ask them to look at it.
Right. But now in this particular case, she's RH, the antibody titers are negative. Would you think that this is an optimal time to give her the anti-D?
Yes. I have always followed Professor Deka from the AIMS, who's done a whole lot of work on RH negative. And according to Madam, she said the moment you get an opportunity, give an anti-D. Because we do not know what is happening during the intranatal, the prenatal period. There can be a lot of exposure, and therefore it's ideal to give an anti-D.
Right. Now, many times, Girija, the patients may not come to you in the beginning. They may come to you at 28 or 29 weeks of pregnancy. So they've missed all the previous tests, but they are RH negative. Would you still say at 30 weeks, would you still give her the anti-D?
Yes.
Yeah, excellent. So this is, I think, a very important point that we have to talk about the antenatal prophylaxis, because that brings down that little bit of fetal hemorrhage which occurs. But another thing which I'd like to bring out here is, after this 28-week anti-D, please do not recheck for the antibody screens, because they are going to be positive. Many a time I've had people panicking because they have checked it and the titers are showing 1 in 16. So once you've given the anti-D, it doesn't really.
Absolutely.
Yeah, absolutely. So now, Girija, this patient has had a nice normal delivery.
One more thing, Sujitra madam, I want to bring, because that would be a question, that if even the anti-D titers have come positive, it's always a good practice to give the anti-D still, even if they have come positive.
If the anti-D titers have come positive, you still want the anti-D?
Yeah, I would still give an anti-D. Yeah.
Okay. Yeah. But then what would you do if the if it is a positive thing, then the line of management would be completely different?
Yes, that would be completely different. But still, like the question about anti-D, which I felt I must take it as an extension, because we are still at large about the exact dose that is essential in some situations.
Right. Okay.
It may help.
We're going to be discussing about the dose just a little.
I'm sure.
But one more point I want to bring out over here is, if this woman goes into beyond 40 weeks, would you then reconsider giving her an anti-D before she delivers, or would you induce her and deliver? Would you like her to go post dates, or would you do an induction by 39 to 40 weeks?
Actually, in all patients universally, madam, I do inductions at 40 weeks, if you ask my protocol, personally, personal level, because I am scared of those IUDs which would happen later.
Right. So generally, it's a good idea in these patients to deliver by 40 weeks.
Yes. 40 weeks.
Then
and
there is
I would like to repeat the anti-D if I had given it very early. If I had given it at 28 weeks, then I would repeat it. Or if I have given it at 32 weeks, maybe I will consider to hold it.
Right. Right. Now this patient has delivered, induced her, and she's delivered her. You've taken the cord blood sample. What are, just quickly run through the test that you would do on the cord blood?
The baby's blood group, I will be doing the direct Coombs test, the serum bilirubin level, because these are important things that we require to look into. So that would be definitely done. The serum bilirubin, the baby's blood group, and the direct Coombs test.
So in this case, she's had a nice normal delivery. Do you suspect that there could be more of an FMH, a fetal metal hemorrhage?
Yes, there is a possibility always, because that is exactly what I mentioned, that we are not aware. And therefore, even if I have given the antenatal anti-D, I will still give her post-delivery.
Okay. No, you've given the dose post-delivery, but would you like to do any other test? Would you like to do a
no
Claha-Bedke test in this particular case?
No.
Right. So, and one more important point is, people are very worried that, when you're giving so many anti-Ds, does it harm the fetus? Well, it doesn't harm the fetus. There is enough evidence to suggest that it is absolutely fine.
It is safe.
Girija, one point which I'd like to ask you.
Yeah.
Whenever you're collecting the blood, say you decide that this patient has got more of a fetal-maternal hemorrhage, is there a limit time to collect the blood? Can you do it then, say the next day, or should you do it within a particular time, say within 2 hours? Is there any
For the clear HK.
for the FIA?
See, within 24 to 48 hours also should be fine. Ideal would be at birth.
Yeah. So generally for the KB test, ideally would be within
5 minutes.
But the vaccination, yes, you can give it within 72 hours. But again, there's a school of thought that if the patient has not been able to, sometimes the public hospitals, the patients are not able to afford. Even on the day 4, we've given the anti-D. So till 5 days, you can comfortably give it, but within 7 days, the best. And obviously, if you have an additional dose calculation, but I want to ask you again, Girija, are you all able to do the Beck test at the public
No.
hospitals?
No, I will tell you the challenge, because this is something which is being talked, and I think we as clinicians must be well versed with. We tried to do a dissertation for one of our postgraduate students, and we failed miserably because we are not able to do this test very easily. Most of the labs are not able to access because they say that there is such a minuscule amount of blood that comes in that it is next to impossible, and they suggest some other spectrometric tests which are really very difficult to access. So we had to change the dissertation topic of my student, and because we couldn't do this test. So
Absolutely.
therefore,
I think some 10 years back, they had looked into these things and they finally found flow cytometry probably is a much better method because feasibility of doing a Claire bed case test and the incidence of, getting wrong results was also very high. But there are times when you're suspecting a fetal-maternal hemorrhage, it's advisable to just give an additional dose. But in the UK,
because I feel, Suchitra, I feel that if you look at the cost factor for giving anti-D or the fear doesn't exist. And if you're talking of the cost, if you look at the cost rise in so many other things, comparatively, anti-D is not so expensive.
Right.
So we can be liberal in giving it.
Right. I think Sita would remember because Sita has worked in the UK where we would invariably be doing the KB test.
Absolutely.
And we were surprised that the doses of anti-D were sometimes double or sometimes even 3 times the dose. And, we never thought that so much of fetal-maternal hemorrhage.
It's such a simple test. I don't know why we are not able to get it done, because it will prevent a lot of isoimmunization when when the anti-D is not been enough for the fetal-maternal hemorrhage that have been more in some women. So I don't know why this is a problem, but it's a very simple test.
I think we'll have to look into this. So can I move over to Kiran? Kiran?
Can I just add one thing before?
Yeah, sure, please. Yeah, sure.
As you asked in the first case, the primary gravida needing to be tested for antibody status, it is important because in our own experience, we've had women, a lot of times, as she rightly said, they might have terminations which they don't want to disclose. But secondly, they might have had episodes in the past, very commonly, like my patient had a history of dengue fever and she had platelet transfusion. So, which is sometimes they don't account for. And if that's not completely matched platelets, they could still be sensitized. So that is why it is important. These things which don't come into our forum, we tend to miss this on history.
Absolutely. And ideally, at the first booking to do the ICT and again repeat it at 20, 24 and 28. Though many of the guidelines mention only 20 and 24, I think the first booking is very, very important.
Dr. Madam Suchitra, can I take your leave, please?
Yes, please. Yes.
I want to say bye to everybody, and I also once again want to remind you tomorrow at 9 a.m. the windows of voting open will be closed at 4 p.m. on 10th of September. Please cast a vote for me. You have to make 2 votes because there are 2 seats for which 3 people are contesting. So please vote for me. Your second vote is also important. Without that, it will be disqualified. Thank you so much.
All the best.
All the best, Girija. And we move over to our next panelist, Dr. Kiran Gupta.
Yes, ma'am.
Thank you, Girija. Bye.
Bye. Thank you. Bye-bye.
Which are the potentially sensitizing events that lead to fetal-maternal hemorrhage?
Thank you, ma'am. Thank you, ma'am, for making me the panelist for this session. The most common events which can cause the fetal-maternal hemorrhage, they can be any sort of abortions, like spontaneous abortion, missed abortion. It can cause the fetal-maternal hemorrhage. Then ectopic pregnancy, there are chances of it hemorrhage in the ectopic pregnancy. Then APH, any antepartum hemorrhage can cause it. Then any invasive procedures which we have done, like external cephalic version, it can also cause the hemorrhage, or any miscarriage or threatened abortion can also cause the abdominal trauma. There is the trauma that can also cause the fetal-maternal hemorrhage, and it can also occur after the post-delivery. If NTD prophylaxis has not been given, then that can be a cause for the fetal-maternal bleed.
Absolutely. And even manual removal of the placenta.
Yes, ma'am. Manual removal of the placenta.
Yeah,
Yes,
yeah. And therefore, wherever you feel that there is a additional, you don't have the facilities for doing a KB test, probably make sure that you've already given an additional dose of the anti.
Yes.
So now we move on through. Is the next panelist? I'm not seeing her. Is she there?
Yeah, I'm there, ma'am.
Yeah, you're there. Nilima?
Yes, ma'am.
In the event of bleeding in the first trimester, is there a need to give anti-D? Jaideep just mentioned, yes, you should give it.
Yeah, but I have heard a very good speaker in recent webinars only. He said that if we are avoiding cramping and any DNC like procedure, it's not never a need to give the anti-D in such conditions when there is a spontaneous abortion.
Right, right. See, the previous school of thought was that if a woman has had a missed abortion, say before 6 weeks, 5 weeks, you've seen a sac, and then there is no growth in that. Probably there was no need to give it because the fetal, the Rh antigen comes only at 6 weeks. But today we feel that wherever there is a problem, if there is a pregnancy related issue, it is safer to give anti-D than not to give it. Err on the side of caution. So if there's a light vaginal bleed before 12 weeks, maybe just a spotting, you don't need to give it. But if there is an MTP or an ectopic pregnancy, any kind of a bleeding where you feel there could be little bit of a fetal-maternal hemorrhage, please give the dose. And now we're not recommending half the dose, we're talking about the full dose. So this is one. And the next question again, Nilima, I'm going to tell you to. Now she's a gravida too. She's had one abortion in the past, and that was a spontaneous abortion at 6 weeks. Now she's again pregnant. She's had a 7 weeks ectopic, and she's come in an emergency situation, rupture ectopic pregnancy, and a surgical intervention is required. She is an Rh negative woman. So in this situation, apart from the other resuscitative protocols, would you consider giving her an anti-D, or would you first check her anti-Rh, anti-D levels and then give it?
Anti-Rh, anti-D levels actually before 18 weeks, it is questionable, ma'am.
Yes.
But I will take the proper history regarding a previous spontaneous abortion. Did she receive the anti-D in her previous abortion? And now as ectopic pregnancy, if there is along with it, there is a heterotophic pregnancy also, surely, as you just quoted, that in any pregnancy, if there is an incidence of pregnancy, you should always try and give the anti-D.
Right. Okay. So any of the panelists have any other opinion on this? Yes, Sita?
I just want to add here that, as you mentioned in the previous case, that maybe we don't need to give for less than 6 weeks, but even 0.03 ml of blood is enough to sensitize a woman. So that is important to remember, that you need a minute quantity of blood. And with regards to that's what I wanted to say. But with any surgical intervention for an Rh negative woman, you will definitely want to give the prophylaxis. And once if she's sensitized, then there is actually no role of giving anti-D after that.
Right. That's very right, because if you've done the anti-Rh, you get the reports within 24 hours. You still have the 72 hours whether you can give it. So when you're looking at this particular slide, the standard dose which we are talking about is, the UK looks at it as in units, but we are looking at a microgram dose, so 300 micrograms in the standard dose, which neutralizes about 15 ml. And therefore, most of the times, that is the dose that is recommended. But of course, there are smaller doses, but the smaller doses are not always available. But less than 12 weeks, if the bleeding has been a recurrent bleeding, then it's better to give her the full dose. And this is again a recommendation which I've picked up from one of the UK guidelines. Before 12 weeks, if there is recurrent uterine bleeding, anti-D is unnecessary in the woman with threatened miscarriage. But if the bleeding is heavy and repeated, please give the full dose. And between 12 and 20, of course, there is no question, you have to give the full dose. At 20 weeks, again, if the patient starts having a recurrent uterine bleeding. Sita, would you like to take that question?
Yeah, so basically what we say is, with the anti-D prophylaxis, the half-life is about 6 weeks. So that is why the recommendation was that if you give it at 28 weeks, you might have to later again. So sometimes some people just give one dose at 32 weeks, and then you don't let these women go beyond term, and that's why you don't need it. And the other important thing, the practical point about the anti-D giving is that you must ideally give it in the deltoid muscle rather than the gluteal muscle, because it's an intramuscular injection, and if you give it in the deltoid, if it becomes subcutaneous, then your injection is actually going to be ineffective. That is just one practical point I would like to mention.
Very
and as I said,
agree to the deltoid use of deltoid muscle. Yeah, it's very much important, because in gluteal many a times we are not at that depth also.
Absolutely.
Right. No, and apart
and every
from that, the distribution of yes. I think
every
nucleate was a
event should ideally
complete what you're saying. Sita, you can
complete.
So
as I said, every sensitizing event. Yeah, so thank you. Every sensitizing event should be taken as a potential for fetal-maternal hemorrhage, and depending on when the previous anti-D was given, we can repeat it later if need be.
Yes, absolutely. Either of Sita and Chinmay, either of you could take this. She's a gravity 2 para 1 with 1 normal delivery. Currently, she's 14 weeks pregnancy. She's already had a nuchal scan and dual marker. She's an A negative blood group. She's come to you now for registration. What is your clinical approach and what investigation should be done? Chinmay, would you like to?
Yes, ma'am. She's a second gravida. I would just ask her by history what was the blood group of the first child and whether she received anti-D. If the blood group was positive, did she receive anti-D in the first pregnancy, post-delivery? So whether she received or she did not receive, I would still go ahead and do the indirect Coombs test to check whether she is isoimmunized at this moment. Sometimes women who have received anti-D may come as ICT positive, and that may not actually mean isoimmunization. It may just mean some of the passive antibodies which are still there in the system. So I'll reassure her and check that the titers, if that is the case. If her ICT is negative, then definitely I will reassure her, but tell her that we will prospectively be checking this in this pregnancy. We'll definitely look at the husband's blood group. If it is positive, we don't know whether it is positive or positive negative, like the heterozygous. So if he's heterozygous, there is a 50% chance that the child might be negative. So if the first child is negative and husband is positive, that's an indication that the husband must be heterozygous. But if first child is positive and the husband is positive, then we have to take all our precautions, assuming by default that we are dealing with a rhesus positive baby in this pregnancy. Now, we did the titers. I think that's your next question, ma'am.
So if the negative, we are happy, but if it's positive, what titers would you get alarmed at? And then what would be your protocol? Now, assuming that this particular case, you had a positive titer. Say it's
yes, ma'am. If I had a positive titer, I mean, every lab actually gives us a critical titer. And that is a specific titer that they give us. It is either 1 in 16 or 1 in 32. So they let us know that according to our lab, this is a critical titer. There's another method, ma'am. We can do a quantitative assessment of those titers, of those antibodies.
Yes.
Absolutely. And then if it is there, we can repeat it after, say, 2 weeks and see if there's some alarming change. But honestly, at this stage, ma'am, with the advent of the MCA Doppler, we have started relying more and more on the Doppler changes as opposed to the titers of the antibody changes. So yes, ma'am. So repeat ICT or repeat antibody testing is only relevant. Repeat ICT is not so relevant, but repeat antibody testing is only relevant if you are looking at it. But otherwise, the MCA, peak systolic velocity on the middle cerebral artery Doppler, done correctly, is almost 99 to 100% sensitive for fetal anemia. So whenever there is fetal anemia because of RH isoimmunization, the peak systolic velocity will be very high. And as you have rightly pointed out here, it will be more than 1.5 multiples of median for that stage of pregnancy. Now, for a quick remembrance, all the obstetricians can remember that for every stage of gestation in weeks, the expected peak systolic velocity of middle cerebral artery should be just double the number. For example, at 16 weeks, it should be around 32 centimeters per second. At 20 weeks, it should be 40. So if it is going beyond that, that's a quick way of learning it. But otherwise, if you send to a fetal medicine center, we can calculate the MOMs and tell you exactly where you are.
Right. So what else? What else would you see on the ultrasound? You look at the fetal MCA, but what else would you like to see, Sita?
I just wanted to add, Chinmay has rightly said, regarding the titers, it is very important to know that the titers, even though there is no critical titer as such, we don't mention, because sometimes with a 1 in 16 titer, you might get high drops, and sometimes 1 in 256, you might not get high drops. So it is important to see. That is why many of the centers, once it becomes 1 in 8 to 16, they stop seeing the titers and they monitor only by MCD. So as such, we shouldn't be bogged down by the critical, titer as such, because the high drops can happen in any of the titers, or it may not happen.
I think before the era of Dopplers, they would just monitor the ultrasound and they would check for development of high drops, which is sometimes very late. But now with the MCA, and that would now the MCA is showing, as Chinmay very rightly said, that you look at the gestation and then you look at double the value. Now you find that the PSV is more than 1.5 MOM at 26 weeks. What would you do after this? You're finding it's rising. How frequently would you call the lady?
Ma'am, if it is more than 1.5 MOMs, that is critical. That is a sign that this fetus might now get compromised because of the anemia. When there is fetal anemia, just like adult anemia, the pressure on the fetal heart is a lot, because it has to pump.
Would you intervene right now? Would you do a cordocentesis?
I won't do a cordocentesis anymore, ma'am, because we don't need to do a separate cordocentesis for diagnosing anemia. But we would directly go ahead and plan for a fetal blood transfusion. And as the first part of that blood transfusion, we would check the fetal hemoglobin.
Okay, so I'm just going to stop you here and say that whenever you have a patient like this, and if you are there, you're not in a tertiary care center, make sure that you've referred the patient to where the expertise is, because cordocentesis or intrauterine transfusion, all these require a certain level of expertise, because cordocentesis also has a lot of problems. See, you just run us through what exactly cordocentesis would be and how.
I would just like to add here that in case you're in a center where you are not doing intrauterine transfusion, so when you see the rising MSV moms, as she rightly said, that is when you need to refer the patient rather than waiting for it to become 1.5, because that is when the baby needs the transfusion immediately as soon as possible. So when you're monitoring the PSV, when you're seeing the graph, it's rising, and that is when you need to take a call and refer them to the appropriate place.
Absolutely. Absolutely. But what I'd like to know is, many times, we talk about fetal MCA being, you can probably pick it up only after 18 weeks. And then there's a limit of 35 weeks. So in this particular window only you're working. So why is that so? Because what changes in the MCA, between after 35 weeks? Why isn't it still reliable to follow?
The of false positives is much higher, ma'am, after 35 weeks.
Yes.
And maybe you could deliver by then also, by 35.
That's one thing. But then what madam is asking is, I think, whether it reflects fetal anemia as well as it does earlier.
Whether it does. Yeah.
So post 35 weeks and post transfusion, both the cases, the MCA false positivity is higher.
Right. So I think between 18 and 35, probably we would be relying on that and maybe consider giving steroids and consider delivery. Supposing she's in a tertiary care center, you have the best of the fetal medicine people. Would you still wait on? Would you consider an IUT in this, and how many times would you actually do it? Sita, would you like to take that up?
Yeah, so basically, if you're planning an IUT, as Chinmay said, we don't do cordocentesis separately. You take the blood, you measure the hematocrit directly, and then you calculate the amount of blood that needs, and then you transfuse it. And then immediately after that also you can check the hematocrit as to how much it has risen to after the transfusion, and then you monitor them the next day. Again, you look at the MCA Dopplers, and then you see them every 2 weekly, and then when you monitor them again, your cutoff for the MCA Dopplers will be slightly high as to when they need the repeat transfusion. Chinmay can correct me on that, and that is how you monitor them.
When you're doing an IUT, are you doing it straight away into the fetal umbilical vein, or are you preferring the peritoneal cavity?
Well, if it's early gestations, you would possibly like to do intraperitoneal, because it's technically difficult during the umbilical vein. But after 18 weeks or 20 weeks, most of the people would do it by the umbilical vein or intrahepatic vein. But that is also. But umbilical vein is the best.
There is also another concept of giving a mixed transfusion where a bulk of it is given intravascular, but to avoid a volume overload, the remaining part is given intraperitoneal. And some studies have said that this leads to a prolonged, you can have a resolution of anemia for a prolonged time.
Right. So generally, I think by 34 or 35 weeks, if you've taken a decision, I mean, you can deliver her because most of the NICUs would be able to take care of a baby by then. But my point is, at 30 weeks, supposing you give her an intrauterine transfusion, when can you repeat it? What is the earliest that you would repeat it? Would it be 2 weeks? Would it be 3 weeks? Or would it just depend on the MC again?
Ma'am, actually, after giving the transfusion, we check and mostly we call them even the next day to check. But a weekly follow up is okay, it's acceptable. And anyway, she's counting her fetal movements and other things like that. So if she has some symptoms, we see her earlier. Otherwise, after a week. And whenever the anemia sets in, we need to repeat it.
How frequently we do the fetal blood sampling, ma'am, Chinmay ma'am, after IOT?
Oh, after IUT, again, we don't do fetal blood sampling for the sake of checking the fetal hemoglobin. After IUT, we do the MCA Doppler again, and the corrections can be applied. Once we know that IUT has already been done, there are inherent corrections also which can be applied to say whether it reflects anemia directly or not. There is an expected fall of hemoglobin post-transfusion, so that can be correlated to the MCA at that stage.
Because we are not actually treating yeah, what I wanted to say is we are not treating the pathology here. The pathology is still going on. We are just topping up, we are just supplementing the baby with transfusion so that we can lead it to a term or a time where we can deliver the baby without it being premature. And
right. But once these babies are born, I think these are the ones you have to keep a watch on. I mean, if you still find that the hemoglobin is very low, they might still need an exchange transfusion.
Transfusion. And ma'am, the thing is, if we have already done intrauterine transfusion and it's requiring repetitions, some of the guidelines say by 34 weeks we should be okay to deliver those babies. But like you rightly said, they will have. And then ma'am, there is a confusion regarding the blood group of these babies also, because when we transfuse, we use O negative blood. So very many times we come back with the report that, oh, the baby was O negative, but you kept on transfusing. But that's all the transfused blood. And subsequently, as the baby starts developing its own marrow and its own blood group, then it will recover. But there will be prolonged jaundice.
Right. But when you're doing the chondrosynthesis, I mean, when you're giving the blood into the fetal umbilical vein before you give it, you can actually take out the blood for when you're hemochronic and also check the blood group at that time.
No, ma'am, that is done. That is part of it, because only when we take out that first sample, we know what is the initial hemoglobin. And then because of the formula count, so we have a team, one of whom does this. That once you know the initial hemoglobin and hematocrit, they calculate the amount of volume that's required for correction.
Yes, and there's a complicated formula, and then I think with that they do it. I know, I've seen that at Adam Mrs. place. Yes, I wanted to know, any of the other panelists, is there any role of intravenous immunoglobulins at all? Because initially, there used to be a talk of the high doses of IVIG, they're expensive, but there is from AIMS, Deka had done that, and she had mentioned that there was some benefit. Any experience at all with this? Kiran, Nilima, Sita, or Chinmay?
No, ma'am. I don't have any.
Only theoretical. I mean, we've read in the papers.
Right. Okay, so I think postnatal management of most of these babies, if they're mild, they have phototherapy. But if they're severe, that's the time when they have an exchange transfusion. But gone are those days when you had a lot more hydrops vitalis and you actually, ended up having a stillbirth. But now it's a lot more better because of MC. I think it has revolutionized the management completely. What I'd like to also check is any other new options today? Kiran, any other new options we have now? I mean, have you all been offering the cell-free DNA at all to patients in the earlier trimesters?
Ma'am, that is, I mean,
I don't have any experience about it, ma'am. No.
Yeah, ma'am, what I want to say is the cell-free DNA has a potential. I don't know why the companies shy away from offering this as a method to detect the rhesus typing, because the initial papers on cell-free DNA were about rhesus typing of the fetus. But all the companies here, they say, yes, we can, but they never get back to us.
I fully agree with you. They promote it for other things, but they've never, but I think this is a very good option.
Very potential. I think it will stop a lot of wastage of monitoring and NTD.
Right, ma'am. Absolutely.
It will save a lot of monitoring.
And one must remember that the blood should be obtained before, I mean, not before 12 weeks, but whenever you're doing it, that particular test, it's valid only for that particular pregnancy. It has to be repeated in the next pregnancy. And
Yeah.
one important thing which I'd like to bring out is if there is a change of partner. We've had a patient who's had 3 consecutive fetal high drops, and she came to us a 4th time, and this time everything went off well because she got remarried. The first husband left her, she got remarried, and everything changed. So these are also, some of the things to be considered. But we'll go on to the case number 4. Kiran or Nilima, you could take this. She's again an RH negative lady, gravida 2 para 1. She had a first normal delivery, but this time she had an abruption at 34 weeks, had an emergency section. Of course, the baby is gone to the NICU, but the baby is fine. This patient was given anti-D at 28 weeks. Now, will you check it? Now, in this case, you're probably suspecting a higher FMH.
Yes, higher FMH. We have to measure it also. If facilities are available.
Yes, if things are available. But I just like to again bring this out. This, as Girija pointed out, and as Jaideep had also mentioned, the Klein-Barkett test. It's not a very expensive test, but somehow it's not available at most. I mean, I would say 90% of the places. But remember,
I just want to say one thing here, ma'am. This is available if your pathologist is willing. Labs are not offering it as a this test, but an individual pathologist might help you, because it's all about measuring high power fields. I mean, looking at high power fields after acid dilution. So some of our blood bank pathologists, they are very cooperative and they offer us.
And they offer it. But at least they could do the Rosette test, and if the Rosette test is positive, then they can do the KB test. Because then you can actually find out, how much more you have to give. Because, as we said, one single vial has 300, and that will probably protect only 30 ml. And you probably could have a lot more.
This is another point, ma'am, in RH which needs to be worked on, because this is something we can do.
Needs to be worked on. So now that you've come on to the parental committee, and you also become a member of ISOPA, please take this issue up.
Sure.
We'd like to, go back to the older times. Amniocentesis was, as students, we always learnt about the Liley's chart and the Quinan's curve. Is amniocentesis, does it have any role at all now? In the older times, yes, we had that role because we didn't have facilities for MCA Doppler. But does it have any role at all even in today's current settings, Chinmay or Sita?
I don't think, ma'am, because the purpose of doing that amniocentesis was to look at the optical density difference from a normal amniotic fluid, assuming that there would be hemolysis and therefore jaundice, because that optical density was looked at for 450 nanometers, which was the yellow range.
Yes.
That is, I think, too late to even see things and find out. Once we've understood the physiology better, and we have understood this, then I think we should follow the MCA peak systolic velocity and the titers of antibodies. But with respect, with due respect to the Liley who gave us this brilliant idea of correlating it, I think after Mari's MCA Doppler paper, the same correlation, the same charts have been converted to the MCA Doppler chart.
MCA Doppler, absolutely, I fully agree. Because knowing directly, absolutely right. Absolutely right. No, but what I would suggest also is that, through Foxy, through ISOPA, we have to take up training modules for people who are aspiring to be fetal medicine specialists, or even if not, if they're working at it, at least to learn how to do this Doppler, or then, refer the patients.
Absolutely.
That you have. So therefore, the Liley's chart, it's more of, a historical thing now. But what we have to also remember is there any role of plasmapheresis if there are very severe cases? Is it happening anywhere in any of the tertiary care centers?
Ma'am, some research, again, cost is a very big factor there, ma'am. Very big factor.
Absolutely.
But I think some of these places, I haven't been able to find out anywhere, but the cost will be in a few lakhs. And but we have mentioned it to patients. They find artificial insemination with an RH negative
is much more better.
Donor is much easier.
No. We've also recommended that, and I think that is an option again when we are talking of newer options. It's a simple option which is easily possible. So coming to the sort of the key recommendations, all RH negative women who've had a cell-free DNA testing, they should be offered this, as Chinmay very out, we must offer it. And if they found that the fetal group is negative, then actually they don't require anti-D at all, unless the woman specifically wants it. Now, if she still wants it, you can give it. It is not going to harm her. But we must remember that those who have not been offered this cell-free DNA, we must continue with the protocol of doing the anti-RH, anti-D titers right at the booking, then at 20 weeks, 24, 28 weeks, and if still negative, please give the prophylactic dose. And as Sita very nicely pointed out, it's the effect is there only for 6 weeks. So if you're going beyond 40 weeks, you probably need to repeat that anti-D dose all over again. And remember, as far as possible, anti-D should be administered within 72 hours. And if possible, wherever possible, Chinmay is promised to look into this as a perinatology incoming chairperson. Look at the appropriate test for FMH, and if we can give birth to the KB test and start using it as a regular protocol. And remember, if a woman refuses, now I would like to ask Nilima and Kiran, there are women who've had sterilizations. Okay, the first 2 times she's had anti-D, the 3rd time she's had a male baby, and she says, I wanted sterilization. She says, I can't afford anti-D. What would you do?
Yes, ma'am. Yes, we may not give the anti-D, ma'am. Is willing for sterilization. Anti-D is not must.
Well, yeah.
But we will have to go to Chinmay, ma'am.
No, I completely agree with you that you may not give, but you may not give because if sometimes they lose a child in a road accident and they want a pregnancy.
Yes.
That may be the thing.
And for the future, if she has a blood transfusion, it's always better. Yeah. So when we were at Sign, there was we used to have these poor funds. We used to collect funds from there, and we would make sure that even if they're having a sterilization, make sure that they get the anti-D vaccine. So, in conclusion, please don't.
One question to Chinmay, ma'am.
Yes, please.
What is the role of measurement of liver lobe in a fetus for diagnosis of?
See, it is a sort of a supportive investigation, because whenever there is erythroblastosis, you are assuming there is extramedullary hematopoiesis, and that extramedullary hematopoiesis is happening mostly in the liver, and the spleen also becomes bigger because the destruction of the RBCs are occurring there. So measuring the liver and the spleen is because you are correlating it with the problems going on inside. But it's not so strong that you can use that as a clinical correlation. So MCA Doppler still remains the
best. Yeah. So in conclusion, even if a woman says, we've had a woman who said, I am RH positive, and and when you actually tested it, she was RH negative. So for them, RH negative and positive is just here and there. So make sure that you have a printed report. The RH typing of the husband, when the RH, husband the testing should be done. Offer maternal cell-free DNA wherever possible. ICT at 20, 24, 20 weeks. I would add on to this saying that we must do it at first booking also. Give the anti-D. Post-delivery, don't forget to check the group of the baby. If RH positive, please give the 300 microgram dose and try to learn how to do a USG MCA Doppler monitoring the isoimmunized pregnancies. It was a very chart which yes Chinmay,
one small point, ma'am, that postnatal blood group sometimes even because of the blood exchange during delivery, the cord blood might come as negative. Absolutely. If the cord blood comes negative, it is a good idea to do a heel prick and check the blood group of the baby before deciding not to give anti-D.
Absolutely. And even at cesarean section, when you're taking the blood, just make sure that you are not, the placenta is not completely separated, because sometimes you can get a wrong blood group of this. So take it immediately. And clamping of the cord, of course, that I think we all know that we should clamp the cord as soon as possible and keep the length of the cord long. But this is a nice chart which I found, and very useful. It just actually run through this chart. The first antenatal visit, you're doing everything. If the ICG titers are negative,
chart is not visible.
Okay. But it's just, repeating what we have talked earlier. This is the same chart that Jaideep had shown, but we just have, they've just emphasized the importance of the MCA PSV, and they've mentioned that 1.5 or more, you keep repeating the MCA PSV, and if you find that it is increasing.
Dr. Suchitra,
yeah.
you have to go to presentation board and click the chart slide because it's a blank slide showing.
Okay. Is that better?
I would like to add a point regarding medical
Go
legal.
to slideshow. Go to slideshow and then click on the chart.
No, I've done that, but it's not coming.
There is some RH incompatibility, so there is some chart incompatibility issues.
No problem. But we've already said whatever these panelists have summarized. But I think as far as RH is concerned, this is one success story, and it's only 1.5 to 2% of patients who have isoimmunizations. And I think by that antenatal dose, a lot of problems have been minimized, and MCA Doppler PSV, I think, is one success story for this particular, the last 15 years. So I think with these two, we should be able to keep down our RH problems. And
one point to add, ma'am,
yes.
regarding the medical legal issue, before delivering or going for any cesarean section of RH negative patient, you should have the blood, means documented also that you have sent the sample and you have collected the blood. Many a times in a hurry, or if the hemoglobin is okay, sometimes it is forgotten, but it is always to be kept in mind that you have to approach the blood banks, and it must be documented that you have given the cross-matching sample and form to the relative.
Right. See, this is a very important point, but we must remember that for any C-section, irrespective of the group, you should have taken group and save and check. Now, if you're in a smaller nursing home, you must have access to that maternity storage, like every hospital which does more than 500 deliveries, they're supposed to have a maternity storage unit, because blood banks may not be there in smaller places. But these maternity storage units always have blood group. So before you start off your C-section, always check that there is an availability. But particularly with RH negative, yes, it's very, very important. So I would say it's important not just for this, probably for every other case. More so when there's severe anemia and RH, because it's a rarer blood group. What we've also done is all our women who are RH negative, we've made a list of the donors. The donor is always there in the blood bank. So quite a few times when there is a shortage, then those people are called in, they give the bloods, because the blood goes through 3 days of testing by the time it is actually available. So, they're asked to donate. So I think this is some practice which can be followed in the smaller places. But thanks very much to all the panelists, Chinmay and Sita, for throwing all the inputs from the fetal medicine point of view, and to Nilima for giving us all the technical inputs of the medical legal. Because as practicing obstetricians, there are so many small things which come up. And thanks for all the tips. Thanks to all the panelists, and thanks to Lakshmi for involving all of us in this particular webinar. Thank you very much.
Thank you so much, Dr. Suchitra. Nobody is allowed to go. Don't be happy. Thank you so much, Dr. Suchitra Pandit, for giving so many practical tips to our colleagues how they should manage these RH incompatibility issues. I know you all have tried your level best to give all the practical tips, but there are a couple of questions which I will be taking after Dr. Anju Soni's comments. So I invite Dr. Anju Soni to give her chairperson comments. Dr. Anju.
Dr. Lakshmi, Dr. Suchitra, it was definitely a beautiful panel discussion. But one thing I wanted here to, when I was going through literature earlier, I found that, in some countries, like in NICE guidelines, they mention that they prefer to give 2 doses of NTD at 24 weeks and 32 weeks. I want your comments on that.
The NICE guidelines don't mention 24 and 32. NICE guidelines mention 28, and if the patient has delivered by 40 weeks, then at 40 weeks. So the newer guidelines, 2016, mentions this, and that's what we've been following.
Now we are having couple of questions. Dr. Uma Maheshwari wants to know how we should proceed if Coombs test is positive at 20 weeks of pregnancy.
And Chinmay can take that question.
Yes, ma'am. Thank you.
Yeah.
If the Coombs test is positive at 20 weeks, that means she's isoimmunized. And if she's isoimmunized, then just like we discussed in the discussion, we have to follow up with MCA peak systolic velocity Dopplers. So that assessment is done initially weekly to see whether it's rising, and then if it's all stable, then 2 weekly. We can also follow with the titers of the antibodies, but doing the MCA Doppler is far more, conclusive, because it tells us even the effect of the antibodies. And then we follow like an isoimmunized pregnancy. If necessary, if it goes beyond 1.5 MOMs, we think about transfusion.
Chinmay, and there are still couple of questions. I hope, Dr. Sita, you are here now for 10-20 minutes?
Yes,
Yeah, I'm here.
5:30? Yeah.
I'm here.
Chinmay, you have to wait till end. There is one question from Dr. Varsha Ghate. Sita, what about MTP pill negative patients? Is it mandatory to give NTD in half dose? I mean, I have not understood.
Even I didn't understand the
MTP
question.
pill negative, is it mandatory to give half dose of NTD? That is what Varsha Ghate wants to know.
MTP
We
pill
never give
negative.
half dose, huh?
No, I think what they're asking is, because there are some recommendations earlier that, less than
early
12
MTP.
weeks, we can give a lesser dose. So if she's rhesus negative and she's taken an MTP kit, then do we need to give anti-D?
Yes.
I think in the discussion, it was made pretty clear that if she is rhesus negative and there is an intervention happening, it is safer to give off the anti-D. The discussion is about surgical termination. So medical termination has not been addressed, assuming that it's all only done for less than 7 weeks. The guideline so far it says that if you intervene before any medical termination, it is better to give it off than that. What is the dose? Like we discussed, currently the latest thing is to just give the whole dose. Half dose, if it is available, less than 12 weeks, you may consider it.
150 microgram dose is not very easily available as well, so it's better to give the entire
50. What happened to that 50 dose? I remember 50
not easily
and
available,
300.
It's not easily available, ma'am.
And NICE guidelines say that cramping and DNC both actually in MTP also with pills there is cramping, so you have to give.
Okay, because there was one question for threatened abortion, if there is only cramps, whether we should give.
Yes,
so Nilima has answered that question. You have to give. There is another question from Shubhda Gupta. How you will explain a weekly positive blood group report? She is gravida 3, para 1 abortion, and she has received NTD in both the cases. So how to explain this weekly positive blood group report? Now she is third gravida.
Weekly positive as in weekly antibody positive, if that is what is the question, because blood group has to be clear. It has to be either negative or positive. So it may be a weak antibody positive, if that is what she is referring to. In some cases, you may have a weak antibody positive, and that will remain weak antibody positive even when you check after 2 weeks. And because you've also said that she's received antibodies in previous pregnancies, there may be some persistence of those passive antibodies in some systems, and that will not become a clinical problem for you, because it's not going to, obviously it's not rising titers, it's not active antibodies, so it's not going to cause any kind of abnormality. But it's tricky for the clinician, so I think you can just start with the same protocol as you would do for any other isoimmunized woman. The thing is, you would know that this is not going to be of any clinical significance.
Because most of the time the titers will be around less than 1 in 4, around that. They wouldn't be increasing, so even if that's weekly positive. So by that also, if we have quantifying the titers, we would know that we can reassure them and say that it's because of the anti-D they have received previously.
Dr. Sanjeev Shah has asked a question: how to diagnose the severity of the sensitization if NTD has not been taken in previous pregnancy?
The titers, the antibody titers would be very high in that condition, and sometimes there may be rising titers that you may see, but otherwise you'd have very high titers of those antibodies. That is the indication of severity of sensitization. Whether this sensitization is going to affect the fetus in utero or not will depend on many factors, depending on if the uterus is rhesus positive or negative, and again, inherent immune system of the mother, inherent immune system of the fetus, lots of things.
As rightly said by Suchitra ma'am, that it will depend on how the mother's it is the fate of the fetus, that how much it will be affected. Many more large titers may also not affect any fetus, but smaller can affect.
Titers can affect. And similarly, even the feto-maternal hemorrhage, if a small amount of feto-maternal hemorrhage may cause sensitization in some women, and a large bleed may not cause sensitization in some women. So this immunological propensity to get sensitized, it depends on individuals, fetus as well as mother.
Nilima, you can answer this question. Dr. Tanmay wants to know what is the role of early cord clamping.
Early cord clamping may prevent the feto-maternal hemorrhage.
So I mean, we have to practice. They want to know is there still a role of early cord clamping we should do or we should not do?
In these patients, we can.
In rhesus negative, ma'am, there are indications for early cord clamping. That's what Dr. Nilima is saying.
Yes.
So these pregnancies.
Okay. Not in all cases of RH incompatibility, they don't need early cord clamping.
Because now Manyata is also asking us for late cord clamping.
Okay. So there are very few indications now in obstetrics where we need to do early cord.
Early cord clamping.
Okay, okay. Ruchi Birendra wants to know what should we do about the NTD at 35 weeks of pregnancy if ICT is negative. ICT negative, she is 35 weeks. Should we give NTD or not?
Well, if she has not received, yeah, she sorry. Yeah. It's okay. It depends whether she has received the NTD earlier or not. If she's not received and that means she's not immune, we still need to give it anyway. If the ICT is negative.
Kiran, you can answer this question. Dr. Jayaprada wants to know whether we have to give 1 to 2 doses of NTD at 24 weeks and then repeat at 34 weeks.
We should give NTD at 28 weeks, ma'am.
Acha, because the questions they have asked at 24 and at 34 weeks.
If we are doing, ideally we should give at 28 weeks. But if you are given it at 24 weeks, then you can repeat it at 32 weeks. 34 weeks.
One of our dynamic postgraduate student, Aisha Khadatkar, is with us and she has asked you if direct Coombs test is positive and baby is negative, should NTD be given?
No.
Direct Coombs test is positive but baby is negative, should NTD be given to the mother?
How much is the possibility of this thing happening actually?
Okay, no, that she has not mentioned. I mean, it's just a one-line question.
I think baby is negative, we should not give NTD.
Yeah, no role of NTD.
No, I think there is some mistake in that report then.
Okay, that is what, because it is contradictory.
Yeah, it's contradictory.
Kiran, Dr. Lakshmi Vani wants to know, should NTD be given in cases of medical abortion where embryonic pole has still not appeared and you have given the MTP pills? So what is the recommendation? Even then NTD should be given or you can skip?
I don't think NTD should be given in these cases, ma'am.
If there is no embryonic pole?
Yeah, if there is no embryonic pole, we can skip NTD in these cases.
NTD was given, but now patient is positive in next pregnancy, ICT. How to manage her NTD titers? Poonam Gupta is asking.
We discussed that, ma'am, I think.
Yes, we have discussed.
She's already immunized.
20 weeks, 24
I just have to bring out one point that in a case of medical abortion, people also ask when exactly should you give an anti-D. So ideally, whenever you are starting off the mifepristone, that is an anti-progestational agent. So after you start off mifepristone, within 72 hours, it is better to give it. Of course, if you don't have an embryonic pole, then it doesn't make sense. But once you've seen embryonic pole there, it's whenever you started the treatment, within 72 hours, you should give the anti-D. But supposing you've forgotten to give it whenever you remember it, but give it.
Just 1 or 2 questions more. I know you all have answered these, but Jayaprada wants to know what is the antibody titer at which we have to deliver the baby. Do we have any such titer?
No. The indication for delivery of the baby will depend on different factors. For example, if she is isoimmunized and received intrauterine transfusions, then you take her at least till 34 weeks and then consider delivery at 34 weeks. If she is isoimmunized but has not required any transfusions, then you pull the pregnancy till 37 weeks and deliver at 37 to 38 weeks. And after that, it's not the anti-D titer which determines when she should be delivered. It is the response of the baby which determines when she should be delivered.
Just 2 more questions. So, para 1, live birth 1, abortion 3 is having recurrent miscarriages at 6 to 7 weeks of gestational age. She has received anti-D injection every time. So now what may be the cause of this recurrent miscarriage and what investigation should be done for her? Dr. Annapurna wants to know.
That's a complete panel.
Yeah, that's a different panel altogether.
Yeah.
Ma'am, one question is asked.
That she has received for RPL.
Ma'am, one question is regularly asked that when to give NTD in IUD.
Yes.
Yeah, after delivery or at the time of diagnosis, within 72 hours of the diagnosis of the IUD.
Yes, and you all have answered again. Somebody has asked, does vesicular mole, missed abortion, blighted ovum, ectopic pregnancy less than 5 weeks need NTD? This is the last question for you all.
Vesicular mole, I would still give because there is a lot of, there is a transmission, the fetal-metal hemorrhage can occur. I would still give it in a vesicular mole. See, to err on the side of caution, it is safer to give an anti-D than not give it. I would look at it this way.
And in case of Bombay antigen, how much dose to be given? Dr. Vijay Lakshmi. In case of Bombay antigen.
We don't normally check for all these antigens, but the only one antigen that has been found to be very sensitive is the KEL antigen. So if your lab does check for that, then you're even at low titers, you will have problems. But we usually don't check routinely for all these MS and Bombay antigens.
The management remains the same. I mean, as you are managing.
Should NTBD be given for chemical abortions, chemical pregnancies?
In that you don't see a sac, isn't it? You don't see a sac, you don't see a pole.
You don't need to give it.
So thank you so much. I sincerely thank two experts, Dr. Jaideep Chang for delivering such a wonderful talk and Dr. Suchitra Pandit for the beautiful conduction of this panel discussion. And they have given all the practical tips to our colleagues for managing these cases. I also thank the chairpersons, Dr. Anju Soni and Dr. Anita Kotwal, who had to leave for some emergency, and all the eminent subject expert panelists, Dr. Kiran Gupta, Dr. Nilima Thakre, Dr. Chinmay Ratha, Dr. Sitha, who is missing. I am missing Dr. Girija Wal, who is not here. So all the 5 eminent panelists for giving their expert comments. I also like to thank Science Integra people for providing the technological support, Seshan, Subbu, Sriman and Sana. I am missing Anuja here. And last but not the least, I am thankful to all the participants for logging in from the beginning and staying with us till end. I wish to see you all at some other platform very soon. Thank you so much. Thank you all the faculties and participants once again. Thank you.
Lakshmi, I'm going to request as the president of ISOPAP, please become members of this organization, because ISOPAP is Indian Society of Perinatology and Reproductive Biology. So please do become members, and we must invite Chinmay also to become the member.
I am a life member, ma'am.
All of us are.
I will also once again appeal to all the eminent faculties and participants, please go to our website. See, there is a very easy process to become member. You have to just online fill the form and you can online transfer the money. Please become member of our ISOPAP organization. It's doing wonderful work, research, academics, everything. I mean, you will really enjoy to be a member of ISOPAP. Thank you. See you all.
Thank you so much for this opportunity, all of us. Thank you.
Thank you all. Thank you
very much.
all the
so much.
I really enjoyed.
Thank you.
Thank you.
Wonderful input from you all.
Nice experience to be.